Hello, dear friends, and welcome to yet another episode of Pulmonology Read Aloud with the Gold COPD Guidelines 2025 Part 2. In the previous part, we have discussed about the initial few chapters of the Gold 2025 document, and in this chapter, we're going to basically concentrate on the part of the guidelines that deals with treatment, but the various options available, management of exacerbations, and further. So let's get started. If you look at the medication list about maintenance medications in COPD, most of the list stays the same, except there are two new additions, as mentioned in my previous part 1 video as well: ensifentrine, phosphodiesterase inhibitor, and dupilumab, which is a biologic. Now, these have been recently added to this table that has been there ever since the 2023 and 2024 document. Now, as you know, ensifentrine is available in nebulized form. It's not available in India yet. The dosage is 12 hourly, and this is still under evaluation basically. And there are newer studies that are underway, so we still need a lot of evidence on this. And dupilumab, which is a biologic, is an injectable biologic that has to be given twice a month, and this is also a new addition in the flowchart. When we talk about the pharmacotherapy on COPD, the guidelines have clearly mentioned that when you give treatment to a patient with COPD, your focus is basically on symptom control and exacerbation reduction. So, most of the trials and studies have looked at whether the pharmacotherapy that we are giving will affect the rate of FEV1 and whether it will affect the exacerbations. Do these pharmacotherapies affect the rate of FEV1 decline, or do they essentially result in mortality benefits is something which is still very unclear. But pharmacotherapy is used as a surrogate marker for the natural course of disease, meaning that if you have to add on more medications to a patient, it usually means that the patient is worsening. So there is a recent meta-analysis that has been mentioned by the guidelines, which was done in 2021 by Dr. Selly in AJR-CCM, which has showed that the rate of decline in FEV1 is to the tune of 5 milliliters a year in patients who are taking treatment for COPD versus patients who are taking placebo. So, if there is a patient who's taking a LABA versus a patient taking placebo, there's a benefit of 4.9 ml a year. And if a patient is taking an inhaled corticosteroid, obviously of the group that will benefit from it, the difference is 7.3 ml a year, meaning that pharmacotherapy will also affect the rate of FEV1 decline. When we talk about bronchodilators, they are going to work mainly by increasing this FEV1 because they will alter the smooth muscle tone and they are going to reduce the dynamic hyperinflation. So, the target of treating a COPD with bronchodilators will be to increase the FEV1. So, these bronchodilators, which are available in stable COPD, as we all know, are SABAs and SAMAs. We are having more and more of SAMAs, LAMAs now as compared to SAMAs, but there are also combination of SABA, SAMA that are being still given. So, the guideline mentions that if you give either SABA or SAMA, as compared to that, if you combine a SABA, SAMA, their effectivity is better, but LABAs and LAMAs will be our preferred drugs over these shorter acting drugs, except only with patients who have occasional dyspnea. For immediate relief, you can give a short acting muscarinic or short acting beta agonist, but overall, all COPD patients should be on longer acting drugs for maintenance. They will improve lung function, they'll improve the health status, they'll improve the dyspnea. Also, amongst LABAs and LAMAs, we have been knowing that LAMAs have greater effect on exacerbation reduction in COPD as compared to LABAs. So LAMAs have to be our priority. Whenever you initiate treatment with any long-acting bronchodilator, your choice should be LABA or LAMA in a patient who has more symptoms or a patient who has persistent dyspnea. Do not give this patient a single LABA or a single LAMA. You escalate it to a combination, which happens with group B COPD. Also, regarding single inhaler therapy, the guidelines have mentioned that when you give even triple therapy or when you give multiple therapy, then using a single inhaler will help in adherence. So, the benefit of using a single inhaler is mostly because of the ease of administration. Even if you give it as an open triple therapy, it may still work. The other thing is about theophylline, which we see continue to be, used. They're still used by a lot of us, by a lot of our colleagues and ourselves, because we've seen that it helps the patients. So, theophylline exerts a small bronchodilator effect in a stable COPD, and this can result in modest symptomatic benefits. So, it is not wrong to add theophylline if needed in patients where you need symptomatic benefits. Now, one of the latest additions, of course, has to be biologics, and we know that dupilumab has received a new placement in the algorithm of management of COPD. It's particularly restricted to people who have high blood eosinophil counts, so T2 high inflammation, and it has been seen to reduce exacerbation, improve both lung function and quality of life. However, we will use it in patients with moderate to severe COPD with frequent exacerbations, preferentially chronic bronchitis type, and those with a high blood eosinophil count. Mucoregulators and antioxidants have had their role. We know that there is a less risk of exacerbation, especially in patients who are of the bronchitis type, so they may be added. And amongst other anti-inflammatory agents, there's always been a stress to prove that statins do not have a benefit in preventing exacerbations and may not be recommended. So regarding inhaled corticosteroids, we have been having clear-cut table, this figure which has been there for the last two or three gold documents now, and the strongly favor for use of inhaled corticosteroid has been in patients with history of hospitalization for exacerbations, more than two moderate exacerbations a year, patients with blood eosinophil count more than 300, and those with a history of concomitant asthma. In patients who have a eosinophil count more than 100, or rather 150 to 300, can also be given along with patients with moderate exacerbation. So it's really important to be in the patients with more exacerbation and more eosinophil count. And coming to the other drugs, the first is the oral glucocorticoids. There's no evidence of giving long-term glucocorticoids. PD inhibitors, again, reserved for chronic bronchitis group, reserved for patients with severe to very severe COPD and history of exacerbations. Roflumilast will improve lung function. It would reduce the exacerbation, and the new ensifentrine will also improve lung function, but an effect on exacerbation has still not been evaluated. And lastly, antibiotics. Long-term azithromycin and erythromycin therapy does reduce exacerbation over 1 year. So if you have patients who had repeated exacerbations, infective exacerbations, you could add long-term azithromycin, but you would remember that preferentially, but not only in former smokers, you should be adding these with exacerbation despite appropriate therapy. So, preferentially in former smokers. And treatment with azithromycin can cause bacterial resistance, it can cause hearing test impairments, it can interfere with other drug interactions, and that is something that one has to be watchful for. Now, coming to this figure on management of patients on LABA and ICS, now this is a very important figure because this tells us that if there is ever an indication for an ICS in COPD management, you should use LABA with ICS and LAMA. So, patient who's on ICS and LABA, if he does not have an exacerbation history, you would want to take off the ICS and just consider LABA LAMA. But for patients who've had current exacerbations and patients, even those who do not have current but have had previous positive response to ICS in LABA, here if the patient has a high symptom load or has a high blood eosinophil count, you would escalate to LABA-LAMA ICS. Only when you do not have a high symptom load, you may continue LABA ICS with a good response. And in patients whose eosinophils are low, you may want to go back without ICS and give him a dual bronchodilation with LABA and LAMA. Coming to the other pharmacological treatments, this is the old table which was there previously also. Amongst this, great emphasis has been added on pulmonary hypertension in this guideline of 2025. They have mentioned that the drugs that you use for pulmonary hypertension are not recommended for patients with pulmonary hypertension secondary to COPD. So we should not be giving them blindly for COPD management. And if we talk about vasodilators also, they do not improve outcomes. They can actually worsen oxygenation in COPD. Do not add them for COPD management. Pulmonary rehab, self-management and integrative care in COPD has always been the limelight. Pulmonary rehab is the only non-pharmacological treatment other than a transplant that can affect the survival of a patient. So it's indicated in all patients with symptoms and having a high risk of exacerbation. We know its benefits and we know that it can reduce exacerbations in patients who had recent exacerbations. So we must involve it for patients who have a risk of exacerbations or who have symptoms. In the surgical and bronchoscopic interventions, the table is same as 2024. It talks about cryospray and rheoplasty in chronic mucus production, targeted lung denervation in patients with bulla emphysema, and patients who have dyspnea. Their coils, valves, bulectomy, and stenting and LVRS could be the option. So this is the same slide set. Again, management of advanced emphysema, the table remains same as the previous gold guideline, where if it's an emphysema predominant phenotype, you would go for a bulectomy. If there's a large bulla, if there is heterogeneous emphysema, you could consider in these patients collateral ventilation or fissure integrity has to be assessed for LVRS, and this will guide whether this patient will be suitable for lung volume reduction or will be suitable for endobronchial valve placement or lung transplant. Again, interventional therapy in stable COPD, same table as 2024, which talks about bronchoscopic interventions, transplant, and lung volume reduction. Now, this is something that has been given a lot of emphasis this year. This is how to look for confounders in a patient in COPD exacerbation. So, what they've said is that whenever a patient comes with a COPD exacerbation, do not presume that it's an infective COPD exacerbation alone. Make sure you rule out pneumonia, you rule out pulmonary embolism, you rule out heart failure, you rule out pneumothorax, pleural effusions, and myocardial infarction and cardiac arrhythmias. So, whenever you're writing down that this patient has COPD exacerbation, be sure that you're not missing a heart failure, a pulmonary embolism, or a pneumonia most frequently. Amongst the exacerbations, most of the data, most of the tables remain the same. The table on diagnosis and assessment talks about how we should do a thorough assessment to see that this patient has COPD and look at the signs of alternative causes of exacerbation of symptoms. As I mentioned, we need to assess the symptoms and the signs, do the adequate tests, and establish where he should be treated at home, in the hospital, in the ICU, and then find out the cause. The classification of severity of COPD exacerbation, there is no change. First of all, you confirm the severity. In a patient with mild exacerbation, his respiratory rate would not exceed 24, his dyspnea score will be less than 5, his heart rate would be less than 95, saturation would be more than 92 at room air, and his CRP would be less than 10. In a patient who has moderate exacerbation, he would meet at least 3 of the 5 criteria, that is, dyspnea will be more, his respiratory rate will be more, heart rate will be more, saturation will be less than 92, and CRP would be more than 10. If you do an ABG, you may see hypoxia or hypercapnia. And in a severe exacerbation, definitely the patient has more dyspnea, more tachycardia, more tachypnea, more hypoxia, and new or worsening hypercapnia and acidosis. You need to differentiate with other conditions and differential diagnosis that has been stressed upon again and again in this guideline. What are the potential indications for hospitalization? Patients with severe symptoms who have suddenly had a worsening of the dyspnea with more respiratory rate and hypoxia with a new onset respiratory failure, new onset signs, not responding to initial medical management, more comorbidities, and insufficient home support would be a good candidate you would keep in the hospital. And how to manage a severe exacerbation? So assess the severity, do a blood gas, do a chest x-ray, give oxygen, obtain serial blood gases and pulse oximetry, bronchodilate the patient by increasing the doses of short-acting bronchodilators. You may combine LABA and LAMAs, or SABA and SAMAs. LABAs when your patient is more stable, and initially you can give short-acting drugs. You may consider oral steroids, antibiotics, NIV, and monitor the fluid status. Again, the whole of the exacerbation part of the guideline is mostly same. They also talk about how generally we need to manage the exacerbations. Indications for ICU care, persistent bursting hypoxia, hypercapnia, severe dyspnea, change in mental status, or hemodynamic instability would be favoring ICU admission with an IV in patients with acidosis, severe dyspnea, fatigue, and persistent hypoxia. For invasive mechanical ventilation, we know that if he's not tolerating an IV, failing an IV, there's a cardiac arrest, cannot maintain consciousness, a risk of aspiration, and life-threatening hypoxia, you may intubate this patient. And the discharge criteria and follow-up recommendations are mostly the same like previous years, where you would, in the first 4-week follow-up, look at how patient is understanding the regimen. Is he taking inhalers? Does he need oxygen? Does he need rehab? What are his symptoms? And once patient is out of the initial window, when you follow him on the long term, you reassess the inhalers, reassess the oxygen need, measure the spirometry and his symptoms. Amongst the interventions that reduce the frequency of COPD exacerbation, there has been an addition that dupilumab, the biologic, has been added. So when we talk about reducing COPD exacerbation, now biologic has a very important role, as I said, amongst the other medication, but it's indicated for patients with eosinophilic type. Amongst the pulmonary hypertension, as I said, there's been a lot of emphasis on pH in COPD, and the recommendation clearly says that if a patient has COPD and group 1 pulmonary hypertension, You treat as pulmonary arterial hypertension with comorbidity according to the ESCRS PH guidelines. If a patient has COPD and CTEPH, which is group 4, you treat as per CTEPH guidelines. If the patient has COPD and severe PH, which is group 3, which is secondary to the COPD, then there needs to be an individualized treatment approach. A blanket treatment with group 1 PH therapy is not recommended. Now the other section, which is on lung cancer, essentially same. Whom would you suspect? The risk factors would be age more than 55, a smoking history of more than 30 pack years, emphysema, airflow limitation, a low BMI, and a family history of lung cancer. This is the COPD follow-up checklist, which is a very nicely laid out checklist, which was available in the last year's guideline segment also, and will be helpful in monitoring our patients. So with that, we conclude the COPD 2025 Gold Guideline Statement in brief. I hope this was helpful. I've tried to just enumerate whatever is written in the text out of these tables, but these tables are helpful to get an insight. I hope that in the coming few years we have more and more guidance on triple therapy, on rescues in triple therapy, on the exact dosages in triple therapy, and so on. And with that, I conclude this series, this video. I'll see you with another new topic very soon. Thank you. Bye bye. Do share and subscribe and like Pulmonology Read Aloud. Thank you and happy reading.